continuing with the complications, we're going into a talk here about pseudoarthrosis, which is a pretty broad one. I tried to narrow this down and be respectful of my time limit. And so here's the agenda. Again, each of these topics I think could probably be a 20-minute or longer talk in and of itself. So I tried to pick out a few select papers and concepts that I thought were interesting or recent for each of these, but this is how I'm going to be breaking it down. So just a brief definition, lumbar fusion was first described in the literature back in 1911 by Hibbs and Albee. It was initially a procedure that was primarily used for treatment of tumor, TB deformity, as well as trauma. And obviously, looking at our current case volume, very few of those initial indications are what we're doing for today. The majority of them are done for degenerative or deformity cases. But as a general or broad definition, as the name pseudoarthrosis or false joint, it actually indicates a failed attempt at a previously performed surgical spinal fusion. And we'll get more into how we define it for each of the procedures later. And just an idea of how common it is, these, as I mentioned at the beginning of the talk, the idea of looking at pseudoarthrosis as a broad topic, each, whether you're talking about deformity, degenerative, lumbar, cervical, different rates and presents in different ways for each of those, but just kind of a general idea. Some of these meta-analyses or large database reviews to try to get an idea of the incidence. This was a study that looked at the Washington State over, I believe it was a 6-year time frame, and there's 471 out of 233 2,300 lumbar fusions, and of the reoperations that were performed, 23% of them were for pseudoarthrosis. And this study, this a meta-analysis looking at for cervical, specifically for ACDF, found a pseudoarthrosis rate of about 2.6% in 1,000 patients based on their review of 17 studies. And then this review article, the reference down there at the bottom, somewhere around pretty broad range, and this ranging from 1% to 21% for posterior cervical fusion. So it is regardless of where you're talking about in the body or what procedure you're talking about, anytime you're attempting a fusion, it is definitely a complication or concern that needs to be taken into account. And so looking at the risk factors, kind of breaking them down, some of them are related to the patient. And I kind of looked at this, thinking about it from the standpoint of just non-unions in general. When we think about in orthopedics, when you're analyzing why a fracture failed to heal or why a fusion failed to occur, it's typically they can be broken down into a failure of stability, i.e. a technical concern, or a failure of the chemical environment. And a lot of times that is more related to patient factors than the technical concerns. And so looking at these and kind of going through them briefly, as is true with most of orthopedics, the risk factors for a bone failing to heal or a fusion failing to occur, smoking is near the top of the list in terms of patient factors, which can lead to a pseudoarthrosis. And this is you can tell by the graphic there on the right. This is a pretty old paper, but is quoted fairly frequently in the literature, where they did 50 smokers, Lamy fusion from L4 to S1, followed out to 2 years. And in this study, they found a 40% pseudoarthrosis rate in smokers compared to 8% in the non-smokers. And additionally, they also looked at the PO2 as well as O2 sat on a blood gas that was taken perioperatively, and found that these values in smokers were significantly lower than those in non-smokers. And so This is one of the studies that contributes to the hypothesis that one of the reasons why smoking leads to a failure of either fracture healing or fusion to occur is the idea that nicotine is a vasoconstrictor and leads to decreased oxygen saturation at the microvascular level when we're trying to get bone healing or bone fusion to occur. Similarly, this is a more recent study. That last study, I believe, was from the early 90s. This is from 2001, looking at, again, the idea of smoking, but I thought this one was somewhat interesting in that you can see down there at the bottom, they followed 54 patients, 54% of their 400 patients roughly were smoking preoperatively, and then they were followed out to 2 years. And the kind of the take home of the interesting aspect of this paper is just that while we typically think of tobacco use as either a binary state of either yes or no, they broke it down based on the rate of smoking or the number of cigarettes per day. And you can see that there's not a significant difference in the rate of pseudoarthrosis between people smoking less than 10 cigarettes a day and the people who are non-smokers. It's the greater than 10 cigarettes per day was statistically, there was a statistical significance in terms of their pseudoarthrosis rate between the quote unquote heavy smokers and the non-smokers. And again, in the interest of time, I think this is just kind of a table breakdown looking at arthrodesis rates this is specifically for lumbar fusion. And the take-home points there on the right. A couple of these papers, the ones I've already shown here, but essentially for lumbar fusion, it's been repeatedly shown in the literature that smoking itself is a significant risk factor. Going up and looking at cervical spine, similar findings where this was 132 consecutive patients, finding that smokers had an 87% fusion rate compared to 100% in non-smokers. And they also found in the study that the use of allograft plus smoking was kind of a double whammy with a higher risk of non-union to delayed union, also higher, they found that radiographically post-operatively, they had a significant loss of disc space height compared to non-smokers. And that was for ACDF, looking at posterior spinal fusion. This actually found that unlike all of these other studies that's been presented, they looked at 158 patients, 26% of whom were smoker. They underwent posterior fixation with lateral mass screws and crest and single institution, and they actually found that there was a 100% fusion rate in both groups. So no significant difference with this study group between the smokers and the non-smokers. But that was more or less looking at cervical spine, similar conclusions in terms of what was found with the lumbar, which is that smoking is a risk factor. Other things kind of continuing in the vein of patient factors or looking at the chemical environment at which we're expecting these fusions of the bone healing to occur. Diabetes was one of the things I was thinking about in terms of potential risk and patient factors. We think about perioperative blood glucose being a concern. But this study from looking at 32 consecutive diabetic patients who underwent lumbar fusion, some heterogeneity in terms of the indications, which may decrease the value of their conclusions, but they found that they had an overall fusion rate of 91%, which is not significantly different from patients without diabetes. And so their conclusion was that the posterolateral lumbar spinal fusion has comparable risks with pseudoarthrosis, as well as a comparable overall risk profile. And then continuing in the vein of other metabolic diseases, we consistently are looking at vitamin D and other labs that are markers of bone health. And lumbar fusion, this study from 1990, the study design was a little the way it was done was essentially that once the patient had developed a pseudo, they were subsequently referred for endocrine evaluation. And 24, roughly half of them underwent bone density evaluation. And so they found that only 3 of the 47 patients who developed pseudoarthrosis had either low vitamin D or calcium levels. And so their conclusion was essentially that this was not a predictive factor for the development of pseudoarthrosis after an attempted lumbar spinal fusion. This was similarly found in a larger study. This was more recent. I cut off the year on this clip, but I think it's 2017, I want to say. This was a larger study group, 150 patients that were fused consecutively. And this was a little bit more thorough in terms of their perioperative evaluation of bone health, looking at T-scores, vitamin D, calcium, and also looking at the documented risks, looking at all pseudoarthrosis as well as revision and arterial failures. And their findings were similar to what was shown in that previous older, smaller study, which was that vitamin D levels were not associated with the rate with the development of pseudoarthrosis or the rate of revision or hardware complication. So looking now, kind of getting, those are the patient factors. Now we're going to start transitioning into the technical or things that intraoperatively we can do to either prevent or increase the likelihood of the development of pseudoarthrosis. This was a study that looked at, we're getting now into the realm of adult spinal deformity. This was 55 patients, about 32 of them went fusion with CREST, and 23 underwent with supplementation with BMP2. No significant differences between the groups in terms of their age, deformity, or the number of levels, and they were followed out to 2 years. And you can see down there at the bottom that the BMP group had a roughly 4% rate of pseudoarthrosis at 2 years, compared to the CREST group had a nearly 29% pseudoarthrosis, and so rate of pseudoarthrosis. And so their paper's conclusion was that it was a competitive quote unquote fusion rate, but they kind of emphasized the fact that this was the additional benefit of using BMP as opposed to CREST was the fact that there was no donor site morbidity associated with the harvest of the CREST graft. And from the same group at WashU, this study's from 2006. This was going beyond just looking at the biochemical or the use of biologics, but instead looking at it's a little bit of a hybrid in terms of the patient factors as well as the technical factors. But they looked at all of their patients that had undergone a quote unquote long fusion, average of about 12 vertebrae to the level of the sacrum with a minimum of 2-year follow-up. And in this group of 144 patients, they found they had about a 24% pseudoarthrosis rate. And their risks, the risk factors that they were able to identify as having statistical significance for development of pseudoarthrosis are listed there. You can see T10 thoracolumbar kyphosis greater than 20 degrees. And interestingly, hip arthritis, which I'm not sure I really understand how that may be contributing to this, but thoracoabdominal approach, older age, and a persistence or greater than 5 centimeters positive sagittal imbalance at their 8-week post-op. And then finally, a lack of, or what they define as a incomplete sacropelvic fixation. And that was spelled out as being either a lack of anterior column support at L5S1 or absence of bilateral iliac fixation. And you can see of the 144 patients, I believe it was 56 of them had incomplete fixation of the sacrum meeting one of those 2 criteria. And things that were not found to be statistically significant included the number of vertebrae fused, whether or not it was a revision. Interesting, whether or not smoking was also whether or not smoking was, or whether or not the patient was smoking, and also the preoperative SVA was not predictive. It was instead that found to be that persistence of the sagittal imbalance at 8 weeks post-op was found to be a predictor of the subsequent development of pseudoarthrosis. And this was same group, larger patient population, again, long fusion for greater than 4 vertebrae, 2-year follow-up. This looked at clinical outcomes with the SRS questionnaire, and they found a similar list of risk factors for the development but you can see there that they, unlike the previous study, found that a fusion of greater than 12 vertebrae, the number of levels fused was a risk factor, as well as the level continuation of the fusion to across the lumbosacral junction was also a predictor of development of pseudoarthrosis. So with that in mind, I started kind of thinking about the lumbosacral junction. In addition to the thoracolumbar junction, seemed to be the hot spot, or some of the higher rates of pseudoarthrosis seem to occur at these locations. So there seems to be a growing trend of maybe multi-rod constructs. And this is a paper that was published in 2017, single center, 31 patients, kind of looking to see whether or not additional rods across the lumbosacral junction, given what the previous papers that I just presented showed, that that's a extension of fusion to, or incomplete fusion at the lumbosacral junction, are risk factors for the development of pseudoarthrosis. This was a single surgeon, single center, and they mentioned in the discussion that the surgeon was initially doing dual rod and then subsequently transitioned his practice to a multi-rod construct because of his own observations regarding the incidence or the rate of pseudoarthrosis that he was seeing in his patients. And so it was a retrospective review, minimum 5 levels and 1-year follow-up. And they found that in the patients that had a multi-rod construct, there was no rod fracture at the lumbosacral junction. And then in the patients with dual rod, 6 patients had rod fracture, 4 of which occurred at the lumbosacral junction. And they made the point that 3 of those, of the 4 that had a rod fracture at the lumbosacral junction, 3 of them on surgical exploration were found to have a hypertrophic non-union consistent with pseudoarthrosis. In addition to extension of the fusion to across the lumbosacral junction, another risk factor within the setting of deformity for the development of complication of pseudoarthrosis is the performance of PSO. Seems kind of intuitive to me, but this was a paper essentially confirming that, again, out of WashU. This was tube surgeon, single center, 2-year follow-up, and they found that in that group who underwent a PSO in conjunction with posterior fusion for spinal deformity, overall pseudoarthrosis rate of 10%, and 61% of the pseudos occurred at the PSO site, with the other pseudos most commonly occurring at those other kind of transitional areas of the lumbosacral thoracolumbar junction. And risk factors, in addition to performing the PSO itself, risk of history of prior pseudoarthrosis or prior decompression, as well as inflammatory arthritis. And they did find, just as a side note, that after they went and pseudoarthrosis was treated, that they had a significant ODI improvement. And I'll briefly review this paper here in the interest of time. This was one that was at our journal club the last time, but just the idea of the decision making that can be made in the perioperative period that can, or a technical consideration that has previously been thought to consider or contribute to, or potentially contribute to the development of pseudoarthrosis or failure fusion. This was a paper that was published last year in the Spine Journal looking at MIS-TLIF. And patients were randomized to either receiving, it was placebo, double-blinded placebo-controlled, and they looked at lumbar fusion and essentially found that not only was there no significant difference in the rate of fusion, but there was significant reduction in opioid consumption in the immediate perioperative period. So here's a table from a Bridwell text that's just summarizing what I just presented there. So moving along, looking at how do we diagnose these, one thing that was interesting to me, I thought, as kind of preparing this talk, is that there's a wide variation in the number of different criteria that are used throughout the literature to assess whether or not a successful fusion has occurred. And obviously different modalities. This was a paper that was done by Dr. Rue, trying to compare 3 different modalities: X-ray, CT, and MRI. And 14 patients that were undergoing a revision ACDF and exploration of fusion, and had their index surgery done at least 6 months, and 3 spine surgeons were blinded and who were not involved with care were essentially asked to review these studies and identify which of these 14 patients did in fact have a pseudoarthrosis, with being compared to the gold standard of surgical exploration and of the fusion site itself. And the conclusion of this, you can see down there, the kappa ratings are the imaging modality that was most predictive with these 3 surgeons was CT scan, with MRI and plain radiographs being far less likely to be able to identify the presence of a pseudo. And so again, as I mentioned, there was a number of different radiographic criteria, and looking at different studies in terms of how the literature has decided to identify whether or not pseudoarthrosis or a successful fusion has occurred. This was a literature review that looked at 59 studies trying to identify trends or most commonly used criteria for determining whether or not a successful fusion had occurred. And they, of the 59, looking at all these 59 studies, they identified 10 criteria, 4 of which were major. And their conclusions, you can see those 4 over on the right: bridging trabecular bone, radiolucent gap, and then angulation or translation between vertebrae were kind of the most commonly seen throughout all of these 59 studies. And their conclusions, when they kind of tried to bring this all together, was the most common radiographic finding to predict or identify the absence of a successful fusion was the presence or absence of bridging trabecular bone. The interpretation of CT was highly subjective, using a criterion of 0 motion. They thought maybe a bit too strict, and their final kind of the take home was cutoff value of less than 1 millimeter movement, with dynamic X-rays confirming fusion seems to be supported by their evidence. And this was a picture from that paper, just illustrating the idea of looking at the difference and how they were measuring the distance between the spinous processes between flexion extension films. So that was cervical, and then looking down to lumbar. It's a similar paper trying to go through the different scoring systems and assessments of imaging to determine whether or not how these studies were defining pseudoarthrosis. And you can see for plain radiographs, they concluded there was a high false negative rate for the presence or development of pseudoarthrosis. One study had 89% sensitivity and 85% specificity sensitivity in another study looking at plain radiographs. And in terms of looking at CT scan and, in terms of why that may be, this was a finite analysis that was done down the street at UCSD, looking essentially like the question that they were trying to address was to look at that wide range of what is an acceptable amount of angular translation or displacement on flexion extension films that was used as kind of a cutoff for whether or not a fusion had occurred. And so this was done through a finite element model, looking at a single level at L3-4. And what they attempted to do, you can see over there, it's a graphic of their ALIF model where they looked at ALIF, PLIF, intertransverse process fusion, and interspinous process. And they modeled out different percentages of fusion and the location within the vertebral body where the fusion had occurred. And essentially what they found was that for each of these procedures, particularly for ALIF, that there was you could have a patient that was 25% fused anteriorly and maybe 50% fused posteriorly. And the degree of, or the amount of angular translation in this model would be essentially equivalent. And so their conclusion, you can see down there at the bottom, that they essentially said identifying a specific cutoff, looking at radiographs and flexion extension films to determine whether or not a fusion had occurred, that there may be it's a little bit more complex than that based on what they found in this. So if plain films have some nuance to them and maybe CT scan, they, again, in that other, looking at beyond plain films, they found that the CT scan had the strongest correlation with the intraoperative findings, which again is the gold standard for the diagnosis of pseudoarthrosis, and somewhere between 57 to 80% correlation with intraoperative findings and sensitivity up to 60%. Bone scan is, according to this article here, that they essentially concluded that because of the fact that there is increased bone scan or increased scintigraphic activity in the setting of a developing fusion, that bone scan itself is a poor marker for the presence of pseudoarthrosis, because you can't really tell whether or not it is a failure of fusion or a developing fusion mass at this time. And you can see this McMaster study at the bottom. This was a setting of adult spinal deformity. At 6 months post-op, 65% had increased uptake at the fusion mass on bone scan, but then subsequently, once they underwent revision and surgical exploration, only one of the patients who was found to have a pseudo. So just food for thought there, that might not be a reliable diagnostic criteria for pseudo. And so these are just, again, from the Bridwell text, a study, a summary looking at both clinical features, essentially new onset pain in the setting of prior fusion, and then some of these radiographic findings that I previously referenced here. So again, trying to stay somewhat, I know I'm running a little bit late here, but say that the pseudoarthrosis has been diagnosed. What is the treatment and how do the patients do? And so this is patients who had 120 patients, single institution had undergone a previous ACDF. 27 of those patients they were treated and revised. And so 27 of the revisions were done with a repeat anterior procedure and 93% posterior fusion. 2-year follow-up, no significant differences in the number of levels or smoking status between the two groups. And you can see similar complication rates between the 4%, between the two groups, slightly higher in the posterior group. But the take-home point is that 44% of the revision anterior patients required a subsequent re-revision for persistent non-union or pseudo, compared to only a 2% with posterior revision fusion. And so the conclusion that they reached was that posterior fusion is more effective in treating an ACDF pseudo. So that one argument for revising an anterior pseudo from the back. This is a study that was done by Dr. Wang, looking at, again, previous ACDF pseudo with, they were treated with posterior fusion and foraminotomy. Just for frame of reference, this is a 2005 study. So they were treated, their surgical technique was either posterior wiring or lateral mass plating, which I don't think we're doing very much anymore. 13 of the patients were treated with crest, and 20 were fused with local bone graft, followed out to about 4 years. They, in addition to looking at the presence or absence of radiographic fusion on dynamic X-ray, also looked at outcomes. And they found that similar to the previous study, they had a very high rate of fusion with the posterior revision. They also found that whether or not the patients had crest versus local bone graft, there was no difference in fusion or patient-reported outcomes. But 28% of the patients that underwent posterior fusion reported moderate to severe cervical pain following surgery. And so the conclusions you can see at the bottom is that while the study did find that you may not need to use crest to address in order to achieve a higher fusion rate based on their findings, that they did think that it was important to emphasize that a 28% rate of persistent moderate to severe neck pain is something that patients and surgeons need to be aware of before making a decision to revise these from the back. And then, so that is revising anterior failure or pseudo from the back. This is a study looking at revising anterior pseudo from the front. And again, going back to that first study I presented, where there was a fairly high rate of re-revision or persistent pseudoarthrosis, this series found that after their revision procedure, which was done about 2.5 years after the index procedure, they were treated either with a revision ACDF or corpectomy if there was significant kyphotic deformity. And they found that their fusion rates were roughly 85%. And so they found that they had an exceedingly high rate of fusion that came along with this. And so I think that's just an argument for, while the first study seemed to say, indicate that there was a, that anterior fusion had a high rate of complication in subsequent pseudo, that may not be found in all the literature. So that was cervical, looking at adult spinal deformity. How did these patients do once the pseudoarthrosis has been identified and treated? Single institution, 175 patients. They looked back retrospectively at 2 years, out to 2 years, and found that of their 175 patients, 12% of them had a reoperation, and of that, 5% was for pseudoarthrosis. And what they found was that at 2 years after they had gone back and been revised or reoperated on for this pseudoarthrosis, the 2-year minimum important clinical difference in terms of their patient-reported outcomes was not statistically significant, significantly different rather, from patients who did not undergo a reoperation. And so the take-home point from this is that in the setting of adult spinal deformity, while it's a fairly common complication, if it's identified and treated, you can get them to the same place as if they had not, for patients who do not develop pseudoarthrosis. And finally, looking at the lumbar fusion and how do they do after addressing or treating the pseudo. 47 patients, revision surgery for development of lumbar pseudoarthrosis for prior attempted fusion. Looking at their, you can see the ODI, VAS back pain, and SF-12 physical health scores. Interestingly, mental health did not have any difference between the two, but after revision, narcotics independence at about 12 months, return to work 4 months, and none of these patients of the 47 they looked at required a re-revision. And so a revision lumbar fusion can lead to a significant improvement in their disability and quality of life, and should be considered as a treatment option for patients with good outcomes. So again, broad topic, ran a little bit over here, but the take-home points are essentially that anytime any fusion that is considered or undertaken and patient comes back with pain, and it can be, as I mentioned, a couple of those studies a ways out, that one study suggested that radiographically it may be out to 3 years before you can see things on plain film for the development of pseudoarthrosis, but it should be high on the list. In terms of the radiographic criteria, given that there's such a wide variety within a wide range of different radiographic criteria across the literature, I think general principle in anything in life is that if there's 37 ways to do something, none of them is particularly good. And so I think you just need to be mindful of the fact that there's no one answer in terms of using thresholds or even specific imaging modalities, and you may end up needing to use a number of different imaging modalities, and being mindful of that finite element analysis. Don't get hung up on the amount of translation or movement that you see, as using that as a hard stop cutoff. And probably most importantly is that if you do make the diagnosis and identify the presence of pseudoarthrosis, re-revision surgery, particularly in the setting of adult spinal deformity, as well as lumbar pseudoarthrosis, these patients actually can do quite well and have similar outcomes to patients who have not had a failure fusion at the index surgery. Thank you.
Great talk, Micah.
Thanks.
That was fantastic. I feel schooled.
Hey, just to reiterate your point, and I think the cervical paper that you pointed out with Jeff highlights that these are complicated scenarios, and much of the time you have axial pain with pseudoarthrosis if you have any symptoms at all, and it's in the context of spondylosis and a bunch of other stuff that might be going on, and so it can lead you into mishaps if you presume that the pseudos are symptomatic. The reality is they are not all symptomatic, and I think some of these thoughtful new imaging studies like SPECT help us glean other pathologies out a little bit. But his findings that, hey, you can go in and revise and get a good fusion and still have symptomatic behavior really underlies the challenge, and you just have to be exceptionally thoughtful. And I think there's also, I might have missed it, but you also have to even think about colonization of the implants and indolent pathogens that exist on the implants. And Sig Bervin pointed that out in one of his studies. So be very circumspect when you work those patients up, from colonization to adjacent segment disease to spondylotic stuff, pseudoarthropathy that's elsewhere, when you're starting to aim towards treatment, because you'll get bitten probably a fair number of times just going and thinking the pseudoarthrosis is the problem.
Got it.
Awesome. And then I'll give you one other final thought. Putting 4 rods in is no replacement for doing a good arthrodesis in surgery. I think a lot of these papers are basically showing that we do crappy fusion, and adding more metal does not prevent, does not replace crappy fusion. So when you're in the operating room, being meticulous about your decortication and your grafting, I think is really important, because I think we're going to see these 5 to 7 year studies with 4 and 6 rods fractured. I don't think it's going to matter. If you do a crappy fusion, it's not going to fuse. It just takes longer for the rods to break.
Well, those guys had internal controls though, so it probably helps.
Yeah, it's just saying it'll delay it, right? You're fracturing. The Sam Cho's paper had rod fractures before a year. I don't know if I've ever had a rod fracture before a year.
Right. Well, I've seen them. I mean, we see them in the ISSG data set when we were looking at the.
And I'm talking about your own patients.
Yeah. So I think it happens, and I think it happens less when you have anterior structural support. But I think, to your point, you put 4 rods in, you probably, if anything, you just delay the failure. I'm not sure you eliminate the failure, you know?
Yeah. Chances of it. Just do a good job.
I
in
also
surgery.
think sometimes the more metal you put in, the less surface area you have for grafting. I mean, there's another spin on things. You load things up with metal, particularly in these lumbar cases where there's lamies done, and now you're running, 2 rods on either side, in the lateral recess or the intertransverse space. You end up really decreasing the amount of area you can pack bone.
Awesome. Well, thanks, Micah, very much.
Yep.
Good job.
Thank you.
Thank you.